This is the multi-casualty incident chapter. So let's say you're called to this scene. You have a rolled over school bus. You're the first unit to arrive at scene. It's you and your partner in a BLS ambulance. Your partner's driving. You're sitting in the passenger seat, so you're the patient care person. You're the person in charge of whatever patients or patient you might have. So the very first thing you're going to do is you're going to call dispatch. Before you get out of the ambulance or fire truck, you're going to call dispatch. You're going to let them know what you have and that you have a potential multi-patient incident. And they're going to want the location, obviously, and they're going to send you a ton of people and a ton of equipment. It's on the way. But in the meantime, it's just you and your partner. So what do? So because you are sitting in the passenger seat, you're the patient care person, your job is to coordinate, at least for the beginning anyway. You're basically the incident commander at scene, and your partner is your helper. So what you can do is you can have your partner go out and safely look in the window of the bus and get an approximate count of patients. You're not going to be treating anybody right now. You're not going to be, splinting and bandaging. You just don't have the resources to help all these people by yourselves. So the best way to help them is you're going to get a rough estimate of how many patients there might be. So in this case, there's 34 patients. There's 32 children. There's one driver, and there's one teacher in there as well in various stages of injury. Your partner is going to come back to you. He or she is going to say, hey, we got about 30, approximately 25 or 30 people in there. And then now you can express that number to dispatch, and then you can also call the hospital, your base hospital, and tell them you have a multi-patient incident and you have approximately 25 to 30 patients potentially, and you'd like to get them to notify the other hospitals because these patients are going to be showing up here pretty soon. And that's right at that point. I'm guessing you're going to probably start seeing the first units arrive at scene. The fire truck's going to show up. The fire captain's going to come out, and they're going to come up to you, and you're going to give them a turnover. You're going to say, hey, this is what I saw, this is what I have, this is who I called, whatever information you might have. And at that point then, the captain becomes the incident commander. So he or she is now in charge of the scene, taking over your role, and then you would be more falling into the role of some type of person helping the patients, moving the patients, treating the patients type of situation, or possibly even transporting them when the time does come. So the definition of a multi-casualty incident or a multi-patient incident is essentially where you have more patients than you have EMS resources. This very seldom happens. In my career of 27, 28 years, 29 years, whatever it's been at this time, I've been on maybe 3 or 4 multi-casualty incidents where we had more than 10 patients. Most of these are usually between 3 and 5 patients, and they're pretty easily run with the resources we have here in the city or the county of San Diego. But really what it comes down to is you arrive on scene and you need to call a second ambulance. Anytime you call for a second ambulance, that should be set up, and you should use the MCI Incident Command System to make this work better. And hopefully, if you're running with an engine company, the captain, who's very highly trained in this process, will have already started that process. He or she will have become the incident commander. They will have assigned someone to do triage of the patients. They will have assigned someone to be on the radio. So this happens pretty quickly. So you might not get directly involved in this other than the transport of the patient process. But ultimately, anytime you have more patients than you have ambulances, then that becomes obviously an issue. Now, I know you might have done your FEMA assignments already, and one of them talks about the National Incident Management System, the NIMS. Basically, as you probably already remember, if you took that online of course, that it's this kind of this overarching document that was developed after all those terrible FEMA responses back in the late 90s and early 2000s. And the biggest concern they had with these responses, if you look at some of the after action reports, is a lack of communication between agencies, lack of commonality when it comes to the equipment they're using. Even the radios weren't even on the same frequency sometimes. So this basically says that everyone should train together, everyone should have common frequencies, everyone should have common equipment that crosses over easily, and everyone should use the incident command system to operate during these mass casualty types of events. Now, the incident command system is just a way of organizing the structure of your response. And it can be as little as a couple of units and some crew members, and it can be a little tiny incident, and it could expand to a gigantic thousands of people, like Hurricane Katrina or one of those larger events, or 9/11. Those incident command systems were unified command systems that encompassed more than one agency and had hundreds and even thousands of people working. And it's a great system to structure this and to respond in some kind of organized manner, essentially. And in most cases, if you have 5 or 6 patients in a car accident, and if you set up the incident command system, you make one person the incident commander, and one person the radio person, and one person the triage person, and go through those different organizational structures, you probably won't get very far into this process. You probably assign maybe 3 or 4 different roles, and by that time you're done and everyone's off scene and gone to the hospital. So these can be as big as you want. The ICS system can expand as big as you need or as little as you need. Now, ICS assignments, incident command system assignments. If you read your textbook, there's like dozens and dozens of assignments that technically you could be assigned to. But these right here, these 5 are the most common here in the County of San Diego that you're going to wind up being assigned to, if you do get assigned to them. So the incident commander, again, like I mentioned before, you might be the IC for a couple of minutes, but the captain's going to show up, and then the battalion chief's going to show up, and luckily that just moves up the hill, so to speak. You might be in this ambulance staging role. You might be a triage person. You might actually be involved in directing the transportation of these particular patients, or you might be on the radio talking to the hospital. More than likely, though, you're probably going to be a scribe to help these people fulfill their roles, or you might be lifting moving patients, or more than likely you're going to be transporting patients to the hospital in your ambulance if you do work on an ambulance. So the first role is the incident commander. And again, sometimes with these unified command systems, there's one incident commander, but it's kind of like a committee of various agencies working together to come up with these solutions to problems. The incident commander for me is they're a form of resource. So the incident commander talks to the dispatch on the radio if you need resources, if you need more backboards, more ambulances, more personnel. You yourself would not call dispatch. You would call the incident commander, and then they would call dispatch to request those additional resources. That way there's no duplication of resources, and it's much more organized that way. So again, if you need help, this will be your contact point while you're at scene. Now, staging manager, this is something that's set up usually early in the process. The incident commander will probably pick one person. They'll give them a clipboard and a radio, and they'll send them to the nearest parking lot whether it's a Walmart parking lot or whether it's a school parking lot or wherever it might be. And this is where all of the ambulances and all of the fire trucks and all of the other apparatus are going to be sent to. This is the staging area for all this equipment, because we don't want all this equipment to show up right at the scene. Your job is going to be keeping track of what's there, what kind of equipment's there, and keep your communication officer up to date, as well as the IC up to date on what your resources are, what's available, how many fire trucks, how many rescue vehicles, how many ambulances, how many helicopters, whatever it might be. And you're going to be, obviously maybe even if you have to remove equipment from these ambulances, maybe stripping them of backboards and scoops and things like that so they can be taken up to the scene to be used prior to the ambulances going to the scene to pick up patients. Triage unit leader, this is another role that gets filled pretty quickly within the few minutes of the scene developing. And this is the person who is going to pick a bunch of EMTs and firefighters, and they're going to go out and they're going to do what's called primary start triage on every single patient they encounter. They're going to grade them based on kind of a color grading system, which we'll talk about here in a couple of minutes. And again, this might be one of the roles you'll be doing. Really quick sorting out of these patients, and then the unit leader, the triage unit leader, would then interact with the transportation officer, as well as maybe the medcom person as well, to let them know how many patients need to be transported and how bad off they are, essentially. Now, the transportation officer, this is the person that every patient that gets transported gets funneled through. So this person stands right there where the ambulances pull up to pick up patients. As the patients come towards this person, the person records the patient's name and other demographic information, what hospital they're going to, by what ambulance, and what time they left the scene. And this is all documentation. They also need to keep track of if there are patients that need to be transported, then they'd have to call the medcom person, and they'd have to find out what hospitals are accepting patients. They'd have to call the staging person to request an ambulance to transport. So you can see it's quite a bit of coordination. And this is why this person would definitely have one of those scribe people with them to help them keep track of all this. There's a lot of paperwork involved and coordination involved in this process. Now the medcom role, this is going to be one single person, and they're going to be talking directly to the base hospital nurse. Normally what will happen is they'll stand right next to or right near the transportation officer, so to help coordinate, do a face-to-face more than likely. But they're going to be talking to the nurse on the radio, and they're going to say, I have 3 patients. They're all red status, immediate red status patients, and they need to go right now. What hospitals are they going to go to? And then he'll report to the nurse what ambulances are taking them and the rough ETA and those kinds of information. Now, in the county of San Diego, we have what's called the county annex. So annexes are various pre-plans that are written and developed to address different issues. There's an annex for earthquakes. There's an annex for wild animal attacks. There's an annex for wildfires. The MCI annex is called Annex D. And so the only reason why we would consider activating Annex D is because what it does is it opens up our resources that are outside the county and even outside the state. So if we have 200 and 300 patients, or even 40 or 50 patients, and we think we're going to need additional ambulances from Imperial County or from Orange County or something like Riverside County, If we activate Annex D, that opens up those resources for us to use. It also it gets the state involved and the counties involved as well. So a lot of this is funded through state mandated money. So it pays for all this overtime and all this extra resources. So more than likely, anybody can activate Annex D. You would do it over the radio to the radio nurse, but he or she, the nurse, is going to get on the county line and they're going to let them know that there's an Annex D activation. And again, that opens up all this resource for these really large events. I would say if you have an event that's less than 20 people and you think that you and the incident commander think that they can be handled with the local resources, Annex D might not be really viable, but that's going to be your call. There's no number anywhere, like it doesn't say how many patients makes up an Annex D. It's just purely going to be your call on that, or the captain's call, or the IC's call. So I talked earlier about the triage. And the term triage is a French word. It means to sort. So you're sorting out the patients based on how bad off they are, the acuity of the patient. There's two types of triage. There's primary triage and there's secondary triage. Primary triage is what happens when you go out, you're looking for your patients, you encounter them, and you do a quick 20 or 30 second down and dirty evaluation. You do minimal life-saving treatment, and then you move on to the next patient. We aren't giving them oxygen at this time. We're not going to be splinting their owie boo-boos. We're not going to put a C-collar on them. All we're worried about is we're gonna grade them using a criteria, and then if they're not breathing or they're squirting blood, we're going to treat those as best we can, and then move on. We have to allocate about 30 seconds or less per patient if we have multiple patients. So there's two views of this. So for the longest time, for as long as I've been in the business, we always used start triage. And the start triage the primary triage anyways, it's still a viable tool for us. So the problem with this is that the training that was provided years ago, and still sometimes is as well now, is let's say you go to there's a bombing in a building, in a theater, and there's a bomb goes off in a movie theater, and you go in to do your primary triage. You walk in the door, the scene is safe, the fire's out and all that, and you hear screaming and moaning and crying, and you look inside this barely lit theater full of whatever it might be, and you see all these patients. Okay, so where do you start? Well, originally, years ago, and even up till just recently, start triage would say you start where you stand. So that basically means the very first patient, the one's closest to you, is where you'd assess that person, and then you move out from there. Well, the problem with all that is let's say the first 4 or 5 patients are stable patients. They're not bleeding to death. They're breathing fine. They have injuries. They've got broken bones and they got lacerations and things like that, but they're not life-threatening. So while you're spending 3 or 4 or 5 minutes going through these 4 or 5 or 6 patients that you're working your way through, the person that's bleeding to death, he's already dead. So we've kind of gotten away from the entire start triage process, and what we're trying to stress now, and most agencies are gone to SALT, and what they do with SALT is very similar to START, except the difference is we go directly to the patients who appear most sick or most injured, the life-threatening ones. So we kind of do a reverse triage, so to speak, in a lot of respects. And I'll go through this. So SALT stands for Sort, Assess, Life-Saving Interventions, Treatment, and Transport. This is the steps you'll go through. So sorting. So let's say you're in that same theater, and you go in, you walk in, and first thing you're going to do, you're going to stop at the door, and in a very loud voice, because remember, this was a blast, and their ears might be, their hearing might be kind of screwed up because of the blast, but you're going to, in a very loud voice, you're going to say, everyone who can stand up and walk towards me, get up and come over here. So these are the walking wounded, the green assessment people, the green colored assessment people. So it doesn't mean they're not injured. It just means that they're able to walk. So let's say half the room gets up and walks towards you. You're going to guide them out the door to another location. And there'll be a firefighter, EMTs there to help them, to treat them and to care for them. So what you've done now is you've taken away all the walking wounded. So everyone else in that theater now is unable to ambulate for one reason or another. The next thing you want to do is you want to say, everyone who can wave, I want you to wave. And those people who can wave, it means they have good mental status. They're able to follow commands. So those are not your primary goal. Everyone else who doesn't wave or is squirting blood or something, those are the ones you assess first. So you go to the people that are still, they're not moving, they're not responding to your presence, or they have obvious blown off limbs or obvious arterial bleeding, things like that. You go directly to those people first. Once those people are triaged and treated in the basic way with just basic life-threatening treatment injuries to like a tourniquet or airway control, and that's about it. Once they've been sorted out, then you go back and assess the yellow, those delayed patients that were aware and were able to respond. Then you would assess them. Remember, the people that are green, the walking wounded, they're already outside being treated by those other EMTs and paramedics out there. So you can see the difference here. This lady up here in the upper left, yes, she has injuries. Yes, she got some shrapnel in her. She's probably bleeding, but she's sitting up. She's looking around. The gentleman down here, I know it's a cartoon guy, but that's okay. But he's listless. His eyes are closed. When you ask him to wave, he doesn't respond. You would walk right past the lady and go right to this gentleman, and you would assess him first, and then you assess her second. So with both of these START and SALT triage processes, we use the same parameters basically for our primary triage. Each assessment should take no more than 30 seconds, and at the end of that 30 seconds or less, you're going to have graded this patient into a yellow, red, green, or gray-black category. Red's the highest priority, yellow is second, and green is third, and then of course gray-black is expectant to die or they're already dead, essentially. So what we use to perform primary triage, we use what's called ARPM. So A is ambulatory, but remember we already had people get up and walk away, so those people have already left. So you already fulfilled the A portion of ARPM. Everyone else in the room gets RPM. So we look at the respirations. If the respirations are greater than 30, they're automatically a red category patient. If we have to open their airway to get them to breathe, no matter what their rate is, they're automatically a red category patient. If their breathing is less than 30, then we have to move on to the next parameter. We have to go to perfusion. So we go to perfusion, we feel a radial pulse. Now, cap refill is not very accurate in adults, and especially people who have poor perfusion. So they strongly recommend just using the radial pulse for these patients. If you don't feel a radial pulse, they're automatically a red category patient. If they're squirting blood, if they have arterial bleeding, and you apply a tourniquet to stop the bleeding, no matter whether they have a radial pulse or not, they get a red category immediate tag, or ribbon, I guess, and they are red categorized. If they have a radial pulse and they're not bleeding profusely to the point where you need a tourniquet, then we have to go into the third category, the mental status. If they follow commands and they can answer questions, so if their breathing is less than 30, they have a strong radial pulse, and their mental status is okay, they would become a yellow category patient. Now, if the respirations are less than 30, if their pulse is present but they're unconscious, any altered mental state, if they can't follow commands, if they can't answer questions, they get a red category tag. So that's ARPM. Always start out with the A, the ambulatory, get them out of there, get them somewhere where they can be treated away from the more serious patients, and then use your RPM to assess the rest of them. So we use these ribbons now, these 4 different colored ribbons. And the reason why this is it's a lot cheaper for one thing, and also they can be easily changed out without a lot of confusion. At some point in this process, if it's a large enough MCI, the patients will probably receive some type of triage tag like you see here. And this is mostly probably going to happen just prior to them leaving the scene. The transportation officer might apply this to the patient and document the number you see there on the little ears, the sides there. They'll tear off the color codes that are not pertinent to the patient. So if it's a red category patient, they would cut off the yellow and the green, and that way it would denote this person as a red category or whatever it might be. But initially, when you're going around, you'll have these 4 colored ribbons, and you're going to be tearing off a couple of feet of it and tie it to some place that's very obvious around the upper arm, or if it's exposed, the upper leg, something rather obvious so everyone else can see it. So again, if the person needs a tourniquet, if they need combat gauze, if you've opened the airway and they start breathing on their own, these all become red category patients. And this is just the minimal treatment that we do within that 30 seconds that we have with each patient, essentially. You can also have bystanders, if there are bystanders there, or even walking wounded that aren't all that injured. You can have them come over if they're willing to do so. They can apply direct pressure. They can maintain open airways. Just show them how to do a head tilt chin lift to open the airway, to keep that person breathing until someone else can come along and transport the patient away from that scene. Once the primary triage is complete, then what happens is a second wave of people come through, and they start to package these patients up. They put them on spine boards, and they transport them to a secondary triage location. If it's a large enough event where they're going to be on scene for a while. In the secondary triage area, that's when they're going to re-triage the patient, recategorize the patient if necessary, and that's where they'll start the treatment of oxygenation and splinting limbs and things like that while they're waiting for transportation to occur. And again, this only really happens on these larger events. If you only have 5, 6, 7 patients, usually this doesn't occur. They go right from where you found them in the primary triage. They get packaged right there, and they get taken right to the ambulance and then to the hospital. When the larger events, 10, 15, 20, 30, 40 patients, because there's going to be kind of a backlog of patients, you got to put them somewhere. So we set up these triage areas, a red one and a green one and a yellow one, obviously. And of course, there's a morgue, the black, gray, expectant morgue somewhere else around the back, hiding, I guess. And this is where they have these large salvage covers, different colors, and they'll set these things up, and you can see where they're sorted out. And remember, if a person goes into the yellow category, and while they're there being re-triaged in secondary category, the EMTs discover this person is more critical than they were, they can regrade them to the red category and move them to the red triage area. So again, there's some flexibility there. You just need to keep whoever's in charge, keep them informed of that transition from one to the other so they keep track of all the patients. Some considerations. Okay, so pediatrics, the definition of someone who's a pediatric for SALT as well as for a START is anyone who appears to be under 8 years of age and who's under 100 pounds, essentially. If you encounter a pediatric and they're not breathing, and you open their airway and they're still not breathing and you cannot feel a pulse, then they get black tagged. So basically they're non-salvageable. You just move on. You do not do CPR on these patients. You just move on. If they have if they're not breathing and but they have a pulse and you open the airway and you give them a couple of breaths and they're still not breathing after your rescue breaths, then you black tag them. So to go over this again, for pediatrics under 8 and under 100 pounds, if they're not breathing, you open the airway, they're still not breathing, they have no pulse, then they get black tagged. If the person has a pulse but is not breathing even after your rescue breaths, then they are black tagged and considered to be non-salvageable. Remember too that there is going to be a lot of patients who are very minor injuries and they're going to want to release or AMA. When you have additional resources, extra manpower to do this, that's when you'd have a couple of firefighters, a couple of EMTs going around, and just all you're doing is filling out AMAs for the people who don't want to be transported, who want to just go home or seek their own medical care. But that's only after you've pretty much taken care of all of the really critical patients. They've already gone off scene, and you have this extra resources to do this. We're done. Oh, one more to go. Look at that. So other considerations is, again, we talked about calling early for additional resources. There is some concern about personnel or personal well-being of the personnel. These can be overwhelming for the rescuers when you see all this death and pain and suffering. And if you feel like you're becoming overwhelmed by the situation, you would want to let your supervisor know, and they put you out of service for a while. You get some food, rest up, and if necessary, you would then go back into service maybe a couple hours later when you feel better about the whole thing. So remember, you can become a patient just based on the fact that you might be overwhelmed emotionally by this situation. And remember too that if it is something like a WMD response, this was a terrorist attack, this also is a crime scene, so that adds some complexity to it because the FBI is going to be there, the local police. It's going to be a crazy scene. Now we're done.